and all of that. Most times, you don't have a center to, you might need to even call to get a mobile incubator. And that is why I'm coming up today to let you know we can pick up your babies, we can take care of them, and we can always refer back to you. Another opportunity you have is talking to our consultant all through the journey. We give you a feedback, so should in case the parents are not in Abuja with us, you have the feedback to always give them. You are in conjunction with the consultant here all through this child's journey. So to locate us, we are 39 Ademola Adetekunbo. Our booth is behind. My number is on the screen, and you can always see me after the program. We are ready to partner with you, and we hope to ensure that at the end of the day, we improve pediatric care in Nigeria, and survival rates for child born too soon get better in Nigeria. Thank you.
Good morning, everybody. Thank you very much, Shakira. You can follow Limi Hospital on Facebook, Instagram, Limi Hospitals, Limi Children Hospital, and Cardio Care. We'll be going on into the next program on the agenda. If you look at your books, we're going to be taking the stroke presentation, but I just want to apologize that, sorry, one of our facilitators is unavoidably absent. That's Dr. Osamwe. However, not to worry, you're still going to get the very best. So to handle this unique session, I'd love us to make welcome heartily, because we're in Abuja Cardiovascular Symposium. So let's welcome heartily Doctors Ilodibia and Dr. Abu Kadri.
Good morning, everyone. Thank you so much for making yourselves available this morning, and we hope we'll make things worth your while. Let me just start by saying that I was told that we should compress this into 30 minutes, and it came late, and that's exactly the way a stroke comes. A stroke can come suddenly. So that's, I think, something that helps to put into context what we're about to discuss. And a famed, though departed boxer once described things like this. He said that the one punch you don't see is the knockout punch. You see every other one, but the one that lays you low, you don't see. So we can start by defining stroke as basically a sudden onset neurological deficit, which could be global or focal, and which arises from a vascular cause and either persists till death or lasts more than 24 hours. So these are very old definition, but still very, very, very important. Now, the outline that we showed earlier probably talked about the learning objectives, and I think it's also good to bring in the caveat of things that we are not necessarily going to treat. You know that when we were in medical school, one of the fastest ways to sleep was to read neurology. So we are not going to bore you with a lot of things about nucleus ambiguous, the nucleus of the tractus solitarius, very dangerous sounding names that sound more like masquerades. So we try to avoid that. We try to make it very simplified. We look at things that actually have very clear clinical relevance. The epidemiology is very simple. I think two things are worth highlighting. One is the fact that stroke is the second leading cause of death globally after heart disease. And the second one, which I think is quite scary, is that 25% of people who are 25 years and above will have a stroke in their lifetime. I think that's very scary, actually. And the longer we live, the more the chances that will happen. So if nothing else, for the sake of that unknown factor, I think we should all pay attention. Generally, we have two types of stroke historically. Hemorrhagic stroke, which accounts for about 80 to 85% of strokes, and then ischemic hemorrhagic stroke, which is the remaining 15% or so. we won't really go into more detail about these types of stroke, lacunar strokes, cardioembolic. They are all in the slides. So we'll proceed to some very, very pertinent physiological concepts. The brain is small in size, but mighty in what it does. It accounts for just about 2% of the body weight, and yet takes about 20% of the blood flow, also takes about 20% of the oxygen, and also takes 20% of the body's glucose requirements. So it's a very, very important organ. And what that translates to is that if there is a disruption of blood supply to the brain for as little as 5 minutes, a lot of those things start ceasing. In fact, within 5 minutes of disruption, patient starts suffering neuronal death. And therefore, since most patients with stroke will come much later than that, effectively what we are trying to do is to salvage the penumbra, the area around the lost cells, really, and which is sad, really, but the truth is that with earlier presentation, we can actually achieve much more. Just a point about watershed zones and watershed infections. We've probably seen scenarios where people with chronic hypertension, long-standing hypertension, had things like maybe just a very, very severe episode of acute watery diarrhea and ended up with an infarct. So that can happen because, as we know, one of the things that happens with chronic hypertension is you have marked arteriolosclerosis. So the small blood vessels distally supplying the neurons, many of them get thickened, narrowed, and therefore they are very susceptible to infarction events. And those around the boundaries of the major arterial territories, so the boundaries between the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery, they are all very vulnerable. The way we can think of it is like, for instance, if you are in Nigeria, those towns, those communities at the edges of states where people have struggled for boundary allocation and boundary distribution and all sorts of things, so they are more susceptible to strokes. Now, Dr. Mariam will talk to us about stroke mimics. That's something we must have seen a lot, so she will shed more light on that.
Good morning, everyone. So as much as stroke is quite common, it's actually more common for you to see patients that may present with something that looks like a stroke but actually isn't. So it's quite important for us to be able to differentiate whether or not it's a stroke. This misdiagnosis is one of the most important things. Imagine you see a patient that you think, oh, left-sided weakness, it may be a stroke, and it actually could be something else. Treatment would reduce the efficiency of what you're trying to gain. So a non-contrast CT is the first thing that we do, but a non-contrast CT is not sufficient enough to make a diagnosis, as it may be too early enough to show signs on the CT. So it's about history. As all our consultants tell us in the hospital, history is extremely important. If you have known this patient before, let's say the patient you know is diabetic and takes insulin, and they present with weakness, somnolence, you may suspect, okay, it may be hypoglycemia. So you do the normal things that we do when we have an emergency. You check the patient's RBS, which is a very small but very useful tool. So things such as that, and then also hyperglycemia on the opposite end. It could also be intoxication. If you know the patient has a history of alcohol use or use of illegal substances or drug abuse, it may present something typical as like a stroke. Now, one of the things that, yes, it may not show ideally in front of you, but you may require a brain CT for, would be a brain mass. It could be that the person has a brain mass, or they've suffered a hemorrhage or a contusion. So if you've been given a history of a recent trauma, you could possibly predict that, okay, this could be this. Now, if it's a patient that you're also treating for epilepsy or somebody who has an epileptic syndrome, you may also think, this could be something else. So it's important for us to be able to differentiate what stroke could be. Let's not just assume, which is what we typically do. Patient presents to you with weakness on one side or some other symptoms, and you think, it's just a stroke, and you start giving normal saline, and you start doing all the things that you typically do. They may be harmful depending on the etiology of their presentation.
Thank you very much for that. Just to add that about in people who present with presumed acute stroke, up to 20 to 25% of them actually have stroke mimics. And that's a very high percentage. And that's one of the reasons why we basically in the 21st century, we insist on neuroimaging as part of the workup for stroke. And that you also should, in fact, even if you are considering treatment, so for instance, thrombolytic therapy in the case of patients who present early enough in acute ischemic stroke, you must, for instance, check the blood sugar. It's actually in all the guidelines, check the blood sugar before you even proceed. So how do we recognize stroke?
So this is a take-home message for everyone, whether you are a health professional worker or not. Ways for us to be able to recognize stroke, I've given a mnemonic which everyone should maybe be able to take home. BEFAST, which is be fast, which is what you want to do if you have a patient that presents to you with symptoms that may be stroke. So the first thing you look for is the B, which is balance. The patient may come to the hospital and there's a bit of dragging of the leg, or they drag their hand, or they tell you, oh, my left side or my right side is weak. So there's a balance loss or weakness in one of the limbs. Another is the eyes. So look at the eyes. They may present with visual deficits. Facial weakness. Some strokes may present with a left-sided or right-sided facial weakness, or a deviation of the mouth. So it's good for you to be able to recognize those phenotypical features in patients. Another is A, which is arm weakness, as I spoke about, loss of balance. The limbs, upper and lower limbs, may be affected. Also speech. They may come to you slurring in their speech. And then T, which is the most important of all, time is of the essence.
Thank you very much. This Be Fast is actually an improvement on an earlier mnemonic of fast. And what was noticed was that a number of strokes were missed with fast. Fast is basically heavily tilted towards lesions of the middle cerebral artery, whereas by adding balance and visual field deficits, you extend more into the vertebro-basilar circulation as well. So it helped to reduce stroke, mixed strokes by up to 5 to 10% in a particular meta-analysis. Can you present the first case to us, please?
So, the first case is a 47-year-old man who was referred to our facility from a private trauma facility where he had an ORIF and an IM nail implant due to a left tibial fracture. He suddenly developed confusion, left-sided weakness, and seizures 2 hours after the surgical procedure. Significant history is that he's a known hypertensive with unknown treatment adherence and also has a vague history of a heart condition from childhood. So the first question is it likely to be a stroke? Yes or no?
Please, the poll.
We'll give you some time to log in. Okay, we have 100% yes. How many people? Oh, okay. I'll give you a bit more time. cardiocare.ng/polls.
So we are hoping it's not a bandwagon effect, the winning party.
Okay.
30 something, 35. Okay, so that's a good synopsis of what I think most people here believe the scenario has painted.
Please, cardiocare.ng/polls. cardiocare.ng/polls. Let's log into it. We're going to use it to answer a lot of questions as we go on and make sure that we are in part. cardiocare.ng/polls. That is the website there. Please go there. We use it to answer questions. You can also ask questions if you have anonymous questions where you don't want to stand up. But cardiocare, please let's go there so that we can answer and partake very well. Thank you.
Good. So the next one. Okay. All right. Thank you for your responses. So the next slide. Okay. That's the next one.
So another question is, what were the person's risk factors? A, he's a hypertensive. B, this vague history of a heart disease in childhood. C, would it be the surgery that he underwent? Or do you think it's A and B, or all of the above? So you can go ahead and also answer the poll. Then we can talk further about it. Okay. I think we all agree that this is the correct answer.
Okay, so I think we are moving. Just a word on surgery. Surgery is very rarely associated with an increased risk of stroke, very rarely. Some series have said less than 1%. You actually have some who had after their cardiovascular or neurologic surgery. So just very rare, but it's possible. Now, for the risk factors, there's a whole list, and I think for the clinician, the most important part of the list is actually the modifiable part. That's what you work on every day in the clinic to try to address. And hypertension, obviously, is in fact, if you look at the interstroke study, a major study which looked at stroke demographics worldwide, the leading cause identified across all regions was hypertension. And then you also have obesity, interestingly, which is actually very strongly related to risk of hypertension. And then dyslipidemia and diabetes, cigarette smoking. And then I think of increasing relevance to us in this environment, including those who have lived like me in the South before, particulate matter pollution is also, has also been associated with increased thrombosis and therefore increased risk of stroke and MI. So that's one of the emergent and relatively novel risk factors. Can we go to the next slide? Then for the genetic, I would say for the non-modifiable, I think the ones you should lay emphasis on are the gender, obviously. So men need to be a bit more careful. And then the fact that we are black, these are things we can't change. And then, especially when we are dealing with stroke in the young, we should remember to ask about family history of that. CADASIL, MELAS, these are exotic syndromes, but they are still there, and we don't really know their prevalence in our environment. Please, next.
So we'll continue with the case that we presented earlier. An urgent brain CT was done for the patient, which revealed a right cerebral infarct, which is the MCA territory, with massive cerebral infarction and a midline shift. So speaking about an MCA territory, the MCA supplies the lateral portion of the frontal and the parietal lobe. So the patient may present with different symptoms. One could be a contralateral weakness, predominantly more in the face and in the upper extremities more than the lower extremities. Together with that could be a contralateral sensory loss as well, also more predominant in the face and the upper extremities more than the lower extremities. Another thing the patient may present with is an ipsilateral gaze deviation, and also, affectation can happen to the Broca's area and the Wernicke's area, which then the patient will present with a Broca's aphasia, which is an expressive aphasia, and a Wernicke's aphasia, which is a receptive aphasia.
And of course, if it's an involvement of the non-dominant hemisphere, we also have hemi-neglect, which is a very interesting phenomenon that we can see where somebody basically ignores one half of the visual field. It's like that part of the world doesn't exist. So that's important too. And confusion also can be seen in non-dominant hemisphere stroke. And in this case, actually, that appeared to be what we had because the man was confused, had seizures. We couldn't really establish hemi-neglect, but the other things were there.
The patient subsequently had a decompressive right hemicraniectomy and was then referred to us for further stroke care, and he was admitted into ICU on presentation. So we have a poll for the medical management of raised intracranial pressure in acute stroke. You can go ahead and attempt to answer. Okay, so that's about 50 people voting and counting.
Okay, so just looking at the answers, yes, there was a reason why we had tweaked some of these things the way we did. Many people have the impression, knocked into our heads from housemanship days and all that, 20% mannitol, 250 meals, it's hourly to run over 15 to 30 minutes and so on. Now, if you look at the literature, it's not a fixed dose. It's a range. Unfortunately, it's a very wide range. You will see some places talking about 0.2 to 2 milligram per kilogram and all that, sorry, gram per kilogram. And that's a very wide range. So many people just stop at, generally say 1 gram per kilogram. You can imagine that for some people, if you just use this fixed dose, it will be too much, especially people who are on the small side. And then for some who are very obese, it could also be insufficient. So it's true you may not be able to weigh a patient who has had a stroke, but you can estimate visually and just estimate and act on that. Then if you are giving normal saline, which is isotonic saline, you are not giving it for the compression, you are giving it for rehydration. And what you use actually for decompression is hypertonic saline, which we don't usually have, unfortunately. Transient hyperventilation basically acts by causing alkalosis, and of course, you know that alkalosis it reduces the blood flow to the brain, so that helps to reduce the amount of blood going to the brain, and therefore the intracranial pressure also reduces by that same token. Okay, so we'll just mention a few things about mannitol. Very useful in stroke, but could also be a double-edged sword. One is that it's fluid. Many of these patients are already on normal saline, and then we add mannitol to the mix, especially if we are using the low concentration one, the 10%, we have to use a larger volume. So even though it will cause a diuresis, but that effect is not immediate. It usually takes about 15, 20 minutes or so to happen. So that means that before then, you can end up, for somebody who already has a vulnerable myocardium, left ventricular dysfunction, which you may not be aware of, you can actually end up overloading and causing acute pulmonary edema. Secondly is that you can over diurese and tip the patient into acute kidney injury, very important. And then we also should be aware that the beneficial effect is most felt in the first 48 hours. Beyond that, you actually have harm because many of them develop hyponatremia with prolonged use, and with that, you actually have rebound cerebral edema. So I think those are the most important things to highlight about mannitol. Thank you.
So physical examination for said patient, he presented dyspneic, well-hydrated, afebrile with no pedal edema, and GCS of 15 with no signs of meningismus. Pupils were equal reactive and accommodating. There was a left cranial nerve palsy of upper motor neuron type with left-sided hemiparesis. The pulse was 59 beats per minute, which was irregular. Blood pressure of 149/102 with an MAP of 118. The heart sounds were S1, S2 with ectopics, and chest findings was bronchial breath sounds with bilateral cross crackles. So here are some complications of stroke, early manifestations. So for him, we discussed that he had seizures, which is some of the early complications of stroke. Some late complications also could be seizure disorders and cognitive impairment with depression as well. So this poll is in respect to the patient. If you would like to attempt the question, quickly, we don't have much time.
Please, let's attempt the question. Okay, all right. So the questions are, it's nice to see everybody's perspective on this. Atrial fibrillation is a known, very key risk factor for stroke. And we remember that on physical examination, we noted an irregular pulse in this patient. And we also noticed that he had coerced by bilateral crepitations. On physical examination, he had been vomiting, he had been fitting, so very likely aspiration pneumonitis is present. And then echocardiography is an integral part of the workup of a patient who has stroke, so that has to be there. And then Holter ECG monitoring cannot be deemed unnecessary. It's also one of the things we look out for. Indeed, it's only when you have done all these exhaustive investigations that you can end up with that category we call cryptogenic stroke. You've checked, you've looked for everything, you can't see anything, and you just give that designation. Okay, so we'll skip some slides now.
Okay.
Yeah.
So this was the ECG of said patient, showing atrial fibrillation with frequent PVCs. The Holter gave us reports of significant PVC-induced cardiomyopathy, and this has already put the patient in an increased risk of sudden cardiac arrest. He also had some significant ST wave changes. This was the report of the transthoracic echo.
We can see the obvious left atrial enlargement. Indeed, in this case, it's actually biatrial enlargement. And we know that the left atrial volume index of more than 34 mils per meter squared is actually an independent risk factor for stroke and sudden death, actually. So it's important you do echo. And without doing the echo, you won't be able to know this and probably not be able to drive hard when it comes to modifying his cardiovascular risk. Okay, so can you just talk us through the basic
principles of acute stroke care? First thing we know definitely we do, I'm very sure in all our centers, is IV fluid therapy, like we mentioned earlier. Normal saline at 1 liter 8 hourly. Now you'd have to make a caveat or some kind of consideration for patients who are in heart failure, as we see typically in our center. So less than 2 liters in 24 hours is preferred. Now fibrinolytic therapy in the form of alteplase, as mentioned, is given when the patient presents less than 3 to 4.5 hours. Now, in our current environment, it's quite difficult to catch a patient within this specific time frame. Maybe the patient had already recognized that something might have happened and then didn't present on time, or maybe took it to be something that was transient and would go away. So I'm sure by the time the patient presents to you, there's definitely a history more than 3 to 4 hours ago. Also, CT must exclude acute hemorrhagic stroke before you consider giving fibrinolytic therapy. Commencement of antiplatelets is very important and should be done as soon as possible once the brain CT has excluded hemorrhagic stroke. Also, prophylactic anticoagulation in the form of subacute enoxaparin can be given within 24 to 48 hours of onset. Physiotherapy is extremely important. Early physiotherapy improves recovery rates in stroke patients. And in order for you to commence feeding, you'd have to do something called a formal swallow test, which is extremely important to avoid aspiration. And then obviously IV mannitol, as we spoke about earlier, if there are signs of increased intracranial pressure, which we'll go into soon. Okay, so it's not there. Okay, so here are some signs of raised intracranial pressure. As we mentioned for that specific patient, he came in, he was vomiting, he was restless, and he did have seizures. So he presented with some signs of raised intracranial pressure, which is why mannitol was used as a management. Some late signs that you may see is further decline in the level of consciousness, Cheney Stokes breathing, and fixed or dilated pupils, papilloedema, posturing. So one of the important take-homes, I think, for raised intracranial pressure is the Cushing's triad. So it's a triad of decreased heart rate, irregular respiration, and a widened pulse pressure. When you see this, now it's important for us to treat appropriately, and we should aim to decrease the intracranial pressure by reversing the cause of the increased intracranial pressure and restoring blood flow. And we do this, like we mentioned earlier, by giving IV mannitol, hyperventilation, elevation of the head of the bed for the patient about 30 degrees, and additional medication depending on the etiology of the stroke, and sometimes draining fluid, and rarely, like mentioned, the craniotomy, which this patient actually received. So this was the brain CT image of the second patient, which I'll go back to. A young female, Mrs. HB, who was transferred to our facility with a 3-hour history of sudden loss of consciousness, when she was noticed to be having a heated argument with a nearby vendor. She was a known hypertensive with poor drug compliance, and her medications were unknown to us when she presented. Prior to her transfer, she was given mannitol and labetalol to decrease the blood pressure. She arrived with a GCS of 3, which means she was deeply unconscious, normal size but poorly reactive pupils, with an elevated blood pressure of 206 over 180 with an MAP of 122. So regarding this patient, maybe we can quickly do an answer poll.
Let's see the case again.
Okay. Young female transferred to our facility with a 3-hour history of sudden loss of consciousness while having an engaged heated argument, with a history of hypertension of 8 years duration with poor drug compliance. Her medications were unknown. Prior to her transfer, she was given mannitol, and she arrived with a GCS of 3, with normal size but poorly reactive pupils and an elevated blood pressure.
Blood pressure was 206 over 80. All right, let's answer the polls. Let's answer the polls. Only 10 people have answered. cardiocare.ng/polls. When you answer the polls, you remember it better. And nobody knows what you answered anyway.
Okay, fine. That's okay. So we are, yes, so some people believe, most people believe she has a hemorrhagic stroke, which is true. And then some people believe she has she may have ST segment changes. And that's important because that can actually happen in the setting of stroke, and you might actually think you are dealing with myocardial ischemia or infarction. So it's good to highlight that it's one of the causes, non-specific causes of ST segment changes. But if you can, and you should, do a troponin as well. I've actually had a case of a patient who had synchronous cardiocerebral infarction. Very rare, but it can happen. Now, so this kind of patient definitely requires intensive care unit support. You can't manage this kind of patient in the open ward, and that's why if you are not in a facility where you can give that kind of care, you should actually move the patient on. Somebody as deeply unconscious as this requires protection of the airways, requires ventilatory support. You can't do that in the open ward, so you need to refer to an ICU. And in view of the marked degree of elevation of the intracranial pressure, and we can actually see an extension of the hemorrhage into the ventricular system, this kind of patient will require, as in this case we actually did, external ventricular drainage. So that's one of the indications for neurosurgical intervention in stroke. The other one we saw earlier, when somebody has malignant middle cerebral artery infarction, is also an indication. In that case, we did a right hemicraniectomy. For these patients, so basically these are the criteria for ICU admission. So somebody who has very severe stroke, and you generally for objectivity use the National Institutes of Health stroke score to determine that. Then somebody who has bulbar stroke, because by definition the person has respiratory compromise, and so people who have large middle cerebral artery strokes, especially of the dominant hemisphere, and then those who have space occupying cerebellar infarcts, and those who have refractory seizures.
So our final case is a 67-year-old male hypertensive patient who developed significant and persistent bradycardia. He presented to our facility with complaints of generalized weakness, recurrent tonic-clonic seizures, and altered consciousness 8 hours prior to presentation. The seizures were of new onset, and his admitting RBS was 8.8. On physical examination, he had a right upper motor neuron facial palsy with hypotonia in the right limbs, with a reduced power on all 4 limbs, and the blood pressure was elevated 150 over 80 with a pulse of 44 beats per minute. This was his ECG, which showed a morbid type 2 AV block. Do you think this is a stroke, yes or no? I think this is one of our final polls.
Okay, so I think we can we can call it's cut short the pole. I think most people are moving in the right direction. So yes, this is a stroke. Now, we remember that we talked about stroke mimics, and one of them, of course, we talked of syncope, which is a stroke mimic, talked of seizures, another stroke mimic, and it's important here because in this case, he appeared, he had a seizure, he had a syncopal attack. He also had seizures, so it's a bit difficult, but we know that seizures can happen for the first time in a patient's life in the setting of acute stroke. We also know that people who have thought paresis, or rather people who have seizures, can have residual focal neurologic deficits. In fact, motor dysfunction can persist for up to 11 to 36 hours after a seizure. So it's actually important that people like that, we shouldn't just assume, oh, it's a seizure. You should remember, an adult having seizures for the first time is good to investigate further. And so we did the ECG, and in this case, we found out he had a high-grade AV block, and therefore one of the things that was done for this patient beyond the normal stroke care was that we also implanted a permanent pacemaker for him. And I even saw him last week. His man is doing very well, and that's the wonders of modern medicine. So in terms of the conclusion, so in terms of the prevention of stroke, we talk of primary prevention, secondary prevention, but beautifully, both of them can be encapsulated in a very easy-to-use mnemonic, which she will run through now.
Okay, so this secondary prevention of stroke is as easy as ABCDE. A being antiplatelet, anticoagulation therapy where need be, and also counseling the patient on alcohol, either use or withdrawal, and reduction, most importantly. B would be blood pressure control. A patient with a history of stroke should aim for a target blood pressure of less than 130/80, with a risk of harm when going below that, which is what we call the J-curve effect. C would be cholesterol optimization. When doing a lipid profile, you should aim for an LDL less than 70 to 100 milligrams per DL, depending on the risk category of the patient. And also C could also go into lifestyle modifications such as cigarette smoking cessation. D would be diabetic control. So if you have a patient who has a history of stroke and is a diabetic, you should aim for a HbA1c target less than 6.5. And most importantly, also exercise. So to conclude, stroke requires a multidisciplinary approach from all different aspects, from doctors, be it cardiologists, neurologists, endocrinologists, neurosurgeon where need be, nurses, physiotherapists, speech and language therapists, neuropsychiatrists, as well as dietitian, because as mentioned earlier, it's a multidisciplinary disease. Hypertension being the main modifiable risk factor for us here in Africa and Nigeria, and treating hypertension and other modifiable factors such as diabetes, dyslipidemia, and obesity to target is key to primary and secondary stroke prevention. Having a low threshold for neuroimaging for us healthcare professionals is key in improving our stroke diagnosis and giving us the objective way of differentiating from it and mimics. And to conclude, stroke is ultimately a clinical diagnosis, so we should be fast in confidently making a diagnosis. Thank you very much.
Sorry, do we have any questions? Sorry. Please, the mic.
Good morning, everybody. I want to use this opportunity to appreciate CardioCare for putting this together. More grease to your elbows. My name is Aino. I work in an occupational health setting. And, well, even before I go, I should also say on the light side that apparently, that yesterday, all the cases that were presented were males. And in this era of gender inequality, that we should have more female cases of, so that you can balance it on both sides. But really, with the stroke, there's a particular scenario that usually plays out. There's some kind of rule that you should do a CT as early as possible. I don't know that maybe there are any radiologists here, but I remember a particular patient that I saw, and we were able to actually get the CT done within 2 hours. Down the line, we were able to establish that it was actually an infarctive stroke, but because in the early periods of after the incident, the patient's brain had not, would I say, displayed the rarefaction issues that could be seen on the CT. And they couldn't, usually with our ancillary lab, they didn't think to do a contrast CT, which may have enhanced it. I don't know if it would have helped anyway. You know, what exactly is the rule now? Because of the fact that, okay, you might not be able to establish if it's infarctive, although with infarctive, you don't see pressure effects, you don't see certain other signs. What is the rule with respect to doing a CT scan? How long after the incident is actually gold standard, especially in this setting where, you know, the funds that the patient may be accessible to is not exhaustive, and you cannot do serially those CT scans. You just have one opportunity, he has done it, and you're not able to establish if it's a infarctive or, you know, hemorrhagic stroke. Thank you.
All right, thank you for your question. I think the first thing to establish is that the CT scan is plain. It's not contrast enhanced. So that's the first thing. We don't ask for contrast enhanced CT for making a stroke diagnosis. Then secondly, the CT scan should be done as soon as possible. So if the person gets into your hands now, aim to do the CT scan. In fact, some places you say as within 30 minutes of getting into your care. So that's the first thing. And then you should also be aware of why you are doing the CT scan. The most important reason is to exclude hemorrhage, not necessarily to confirm infarction. Is to exclude hemorrhage because that's the one that the treatment pathway is a bit different. And then if the person comes in within the window period that you are, that bears hope, which is within the first 3 to 4.5 hours, if there is no evidence of hemorrhage and you are clinically convinced that it's a stroke, then the patient can benefit from thrombolytic therapy. So that's actually the reason for doing the stroke. You might also be lucky that with that CT scan, you can find out that there is a stroke mimic in place. So it could just be a mass rather than an actual stroke. Then part of it too, we should remember that, yes, you may not see anything, but you know, it's just like seeing something with the naked eye, seeing something with magnifying glasses and so on. So there are some early signs which probably only radiologists will pick. You usually talk of like the hyperdense medullary artery sign. You talk of the insulary bone sign. These are things that can be seen by very experienced eyes. And you can also see a mass effect. You may not necessarily see an obvious area of hypodensity or hyperdensity, but you may also see a midline shift. So it is still very important, and the guidelines put it at the top. It's a class 1 indication. You cannot manage stroke in the 21st century without actually doing a CT scan. And please, it is a plain CT scan. Thank you.
Thank you so much, presenters, for the presentation, and CardioCare, thank you so much for the symposium. My questions, I practice in Nasarawa State, and we noticed that more of our patients have their, according to the books, hemorrhagic stroke is about 15%, ischemic stroke is supposed to be about 80%, but we noticed that we have an increased number of patients coming down with intracerebral hemorrhage. I don't know if that is a trend in certain regions, and what can be the possible explanation for that we see more patients now having hemorrhagic stroke, almost about 40% of patients that we see recently. So is that a recognized trend, and what could be the possible explanation for that? Then some neurosurgeons are pretty skeptical about commencing IV mannitol for patients who have intracerebral hemorrhage, given that some people feel that it encourages hematoma expansion in the acute period of an ICH. So what is your take on that? And is there any evidence to indicate that that is something that we should be wary of? Then, according to the presentation, enoxaparin can be commenced between 24 to 48 hours of an acute stroke. So are there some situations where we'll be wary of that, given that we are afraid of a hemorrhagic conversion of an ischemic stroke? Thank you.
Thank you very much. So I think we can easily identify that you're not one of those lulled to sleep by neurology because of the beautiful questions you've asked. Now, let me just start with the demographics you've mentioned. You know, demographics are not fixed. You can go to, like in these data we have are usually from the Western environment. So you have a lot of, much more of ischemic stroke there. But incidentally, studies have shown that those are fairly replicated across the world. But having said that, even in the West, there's an increasing prevalence of hemorrhagic stroke. And I'm not surprised too, it's happening here. Hypertension is underdiagnosed here. There's a lot of alcohol use here, and we know alcohol raises blood pressure acutely, so that increases the risk of hemorrhage. And then, of course, the upsurge in the use of illicit substances, amphetamines, cocaine, and so on. These things are available right now in our environment, and these are things that are more found in people who have intracerebral hemorrhage. We also should know that a number of patients are now, we actually have more patients on anticoagulation for various medical reasons, and therefore it is very likely we're going to have more and more intracerebral hemorrhage. Now, for the issue of mannitol and increased intracranial pressure, it's a very controversial thing. What we have done is to adopt a middle-of-the-road approach. Many authorities are not convinced that mannitol offers any benefits, quite frankly. If you do a Cochrane review, you will see a lot of divergent opinions. But anecdotally, it seems to work, but the key thing is selecting the patients right. For people who have intracranial hemorrhage, we know that there is a very sharp rise in intracranial pressure at the beginning. It's like a peak at the beginning. And it does not seem to cause any harm in that subset of patients. Whether it is always the best measure is open to debate, but as you can see from the presentations we made, there are other modalities. So if we judge with the neurologist, the neurosurgeon, with a judge that that may not be the most appropriate intervention at that point, there are other modalities, for instance, the compressive remic cranectomy we talked about, and even the external venous ventricular drainage as well. Want to chip in?
Yes, so I'd like to chip in that SICH, spontaneous intracerebral hemorrhage, is still a medical diagnosis, and the treatment is medical. So treatment is by physicians, not by neurosurgeons. Neurosurgeons are invited in when there are certain indications. But Chief has rightly said just now that the benefit of mannitol needs to be carefully weighed. But in most patients with spontaneous intracerebral hemorrhage, there's rizatriptan, and the benefit from most of the studies suggest more of benefits and less of harm in that regard. The part I want to chip in again is towards the last question concerning the prophylactic anticoagulation. Prophylactic anticoagulation is important in stroke, and particularly when you have more severe deficits. But of course, you're right, the risk of hemorrhagic transformation is always there, and you need to dance between the devil and a deep blue sea, okay? And, but starting in 24, 48 hours, the risk of hemorrhagic conversion that will contribute is quite minimal, frankly. And I think we need to individualize patients and do individual risk assessment of DVT and then assess the risk for hemorrhagic conversion. And that means that there will be a few patients in which you are reluctant to start in the first even 48 hours. You want to delay it a bit further, and sometimes you need to start quite early. So if you have a very obese patient, that have very dense hemiplegia, your risk of DVT is quite very high. And we do know that, from my experience, I'm sure you've experienced patients that are starting physiotherapy and then next day or next 2 days, they throw a clot, or you're about to discharge them, they throw a clot. So you want to prevent that as much as possible. Thank you very much for those questions. I think we can take one or two more.
Sorry, can I just add a little bit more to that? There are risk factors for hemorrhagic transformation. It doesn't just drop from the sky. One is reperfusion. So whether you've done endovascular treatment, that's thrombectomy, or whether you've done fibrinolytic therapy, these are established risk factors. They increase the risk. If the patient is elderly, the risk is higher. If the patient has hyperglycemia, the risk is higher. So these are well-established risk factors. Of course, if you have up to more than a third of the cerebral hemisphere involved in infarction, the risk is higher. And also the thing about individualizing care. If the patient has a coagulopathy, and that's why your history taking is important, and you may need to go beyond the usual investigations to identify those risk factors. So if the person has thrombocytopenia, if the person has a family history of coagulopathy and all that, you may be you obviously will be concerned about starting anticoagulation. Thank you.
So thank you very much for the opportunity. My name is Dr. Yakubu. I have two questions. The first one is to do with the timing between ischemia and necrosis. I think before now, the knowledge is 3 minutes, but you said 5 minutes. And I think it's statistically significant, the difference. So I want to know what has happened. And then my second question is, some patient with stroke, you know, in some cases, you know, she mentioned the wide pulse pressure, and that's where I want to address. I want you to address a specific thing, and that thing is, what is your drug of choice in a patient with a wide blood pressure of 170/70? 170/70 millimeters of mercury. Thank you.
Okay, thanks for the question. Now, with regard to the first question, very simple. It depends on the literature you have read. Whether it's 3 minutes, 5 minutes, all we know is that within the first 5 minutes, it is complete. Histologically, you start seeing evidence of liquefactive necrosis within 12 to 24 hours after a stroke. But the clinical event has happened within the first 5 minutes. So I think it's maybe statistically significant, but I'm sure that from the nursing station to the A&E will probably take more than 3 or 4 or 5 minutes. So I think that sorts itself out. Now, for the second question, wide pulse pressure. You know, there are a lot of cardiovascular risk factors related to blood pressure. So we talk of, for instance, people who have labile hypertension, people who have master hypertension, people who have nocturnal hypertension, people who have high blood pressure variability over a 24-hour cycle. We also talk of even this wide pulse pressure you're talking about. And then, among all of them, I think consistently, systolic blood pressure is the major driver of cardiovascular events beyond the age of 50. And in as much as you are worried that there could be a drop in the diastolic pressure when you institute treatment, the most important aspect, epidemiologically, clinically, is your systolic blood pressure. Now, the mean arterial pressure may also be of concern, but generally, in the setting of loss of cerebral autoregulation, at the end of the day, if you're able to maintain your cerebral perfusion pressure between 60 and 80, which you will achieve if your mean arterial pressure is between 65 and 110, there's really no issue. So at the end of the day, acute stroke, blood pressure control is the guidelines are very clear. Maintain it within certain parameters. Permissive hypertension in acute ischemic stroke, and then reduce to 140/90 or there or less in hemorrhagic stroke. Thank you. Sorry, just to add, if you are concerned about blood pressure variability, of course, amlodipine is unique in that regard. And then long-acting medications like telmisartan 2, excellent profile, 24-hour profile. These are drugs that have been known to help with that. But practically, because we see a lot of patients with aortic regurgitation and all that, we have very high pressures as a result of the loss of the elastic recoil of the aorta. It is still the systolic pressure that determines our blood pressure reduction aggressiveness.
Good morning. Thank you very much for your presentation. Please, I have a question regarding the early initiation of anticoagulation therapy for suspected strokes. In resource poor settings, as the guidelines state as well as your presentation, you need to have a CT scan before you initiate therapy. However, for resource poor settings, it's noticed that you really do not have the facilities in those places. And by the time you send them out to refer them to go to the central areas to get those CT scan, the damage would have likely been done and they have a worse prognosis. So my question is, could there be certain clinical symptoms, your patient presentation, perhaps he's complaining of increasing intensity of his headache, that could clue you in that maybe this patient is experiencing hemorrhagic stroke as regards to an ischemic stroke, seeing that in this our setting, the higher incidence of ischemic stroke as well. Could it be that you could just give maybe perhaps aspirin, and then you send the patient on to get the CT scan in the city? Thank you.
So thank you very much for your question. I do agree that we work in resource-limited settings often. First of all, while we said that it is critical to do neuroimaging in stroke, it does not mean that you cannot treat without neuroimaging. That will not be correct. Okay, so you should start treatment for what you can see, ABC of resuscitation, do every other thing you know, and but neuroimaging is critical in the management of stroke. And no, it will not be appropriate to give aspirin without knowing a subtype of stroke that the patient has, because a small bleed can behave like an infarct and vice versa. So it's until you actually see the brain and you see a CT scan that tells you that there's no hemorrhage, there's absolutely no other way to know. Now, there are several scoring systems, and none of them is near perfect enough that you can risk your license, not to talk to risk a patient's life on it. So none of them work near enough to be close to what neuroimaging will tell you. So if you're unable to get neuroimaging, just do all the other things you can see. Take care of the airways, maintain the breathing, watch the blood pressure, give IV fluids, start physiotherapy until the day that the patient can do a CT scan. And then once you subtype the stroke, then you can give the the pathway-specific treatment for the subtype of stroke that the patient has.
Good morning. I just want to add, like you said, in a resource poor center, using symptoms like we said, I know we used to talk about a hemorrhage, stroke, but if you use some symptoms, it may give you some clue. Patient with headache, seizure, stroke occurring after activity, vomiting, very early, very high blood pressure, all those things look closer to hemorrhagic than ischemic. But like we said, what you may need to do is play a bit safe. No aspirin until you are sure that there is no bleeding. You can do your normal saline. You can do your normal saline. Even statin, the use of statin is also controversial in patients with hemorrhagic stroke. So you need to be careful. There's no other way to say it. Neuroimaging is essential. It's like managing someone with hypertension without doing an ECG and echo. So we should try to do it. And like my chief used to say, we most of the time assume that patients don't have money. But when you tell them that this thing is life-saving, you'll be surprised that those tests will be done. But if you assume, because the way you are looking at them, that they don't have money, they too will tell you they don't have money. But if you tell them that their life depends on it, those tests will be done. But like I said, your normal saline, things that you know are safe, but aspirin, please, we should be very, very careful. Thank you.
Just one more question.
Is there any other question? We have time for just one more question.
Thank you for the presentation. My name is Dr. Jaffer. I had an experience with an 80-year-old man that presented with a CT-confirmed hemorrhagic stroke. It occurred for 48 hours prior to presentation, but he also had a right lower limb DVT, Doppler confirmed. So how would you have managed the situation? Thank you.
Thank you very much. So two things to say. Number one, now it's controversial and sometimes I'm scared of it myself, but after 2 to 4 days, 4 days definitely agreeable with most people, you can start anticoagulation in people with hemorrhagic stroke. Prophylactic though, not therapeutic, after about 4 days, but it's quite daunting many times. Well, that is in the guidelines, is in the AHA guidelines. But when we have a scenario like that, it's quite tricky because giving therapeutic doses is quite high, and frankly, there's a high risk that can extend your hematoma in the brain. And your best bet in such cases is to put an IVC filter. So there are IVC filters which we do put, and we've put in maybe 1 or 2 patients in that clinical scenario. An IVC filter is a filter that is a mesh that stays in the inferior vena cava and can prevent any clot from lower limb from going to the heart, and it can be a temporary measure until the patient is most useful in patients that have contraindications to anticoagulation, which would be like that in this case. In the absence of that, it can be difficult, but I'll encourage us that after day 2 to 4, you could actually place such patients on some amounts of enoxaparin. Now, whether you're comfortable enough to use therapeutic doses or not is going to be debatable. But the guidelines do recommend that after 4 days at most, I think the most conservative guideline says after 4 days, in hemorrhagic stroke, you can actually start prophylactic anticoagulation. Now, that comes with a lot of caveats, which may not be practical in this environment. So you must be able to monitor both clinically and radiologically for extension of any hematoma in the head. So you must be ready to do serial CT scans or MRIs just to make sure that you're on top of the game. I hope that answers the question. Want to add something? Okay, time has gone. Let it start. We can take. We can take 1 or 2 more questions. We are still setting up for the next presentation.
Thank you. My name is Chinwe Ugochukwu. I'm a physiotherapist. So I have 2 questions. The first one is, we talked about spheric neglect. And as a physiotherapist, I'm concerned, in a ward when you have a patient that you're already aware that he has one side that is neglected. So how do you position such patients in the ward? Because I really need to know, how do you position such patients in the ward that will at least help the patient to, maybe focus on the neglected side. So how do we position such patients in the ward? Because of concern to me as a physiotherapist. Then secondly, where do you place the IV on the affected or on the affected side? So please just enlighten us with that.
Thank you very much for the questions. So for the patient that has neglect, there's really nothing too particular about the positioning, but usually, of course, the things you want to get the attention of the patient has to be on the side that the patient is paying any attention to. It's a spatial issue, so if you want the patient to be able to pay attention to these things, that is, if the nurses are going to be coming in through here and things like that, then let that be on the side that the patient is paying attention to. Because if the nurses are trying to serve the patient from this side that the patient is neglecting, really you're going to have difficulty in getting the patient's attention on that side. So that would be what I would say about the positioning of that. But it can be a very terrible symptom, and sometimes it can make it difficult for you to even delineate some of the other symptoms that the patient has. So if the patient has sensory symptoms, the patient may actually be feeling the sensation, but because it's neglecting that side. So that means you can't make judgments on even motor or sensation and even vision when the patient is absolutely neglecting a side. That's one.